Okay, so when we think of HCV transmission in Canada and new cases of infections, we know that the majority of cases occur in people who inject drugs, between 60 and 80% of new infections. And fortunately, we have quite effective tools for the prevention of hepatitis C. And I think among them, opioid agonist treatment, or OAT, is the one for which we have the most consistent evidence to support its prevention benefit. So on the left, you see data coming from a systematic review that was published last year, showing that, so the authors pulled data together from several studies and concluded that on average, people who are on OAT have a 50% lower risk of infection. So it's not surprising that OAT is any public health guidelines on HCV prevention and elimination endorse OAT as a key prevention strategy. So if we know that OET works, then why revisit the question? And one thing that we were interested in with this study is what role does the dosage of OAT play in this relationship? And we know from the addiction treatment field that generally higher doses are associated with better treatment outcomes, reduced symptoms of withdrawal, craving, illicit opioid use. And for that reason, there are minimum threshold recommendations that are outlined here, which are found in clinical guidelines for the management of OAT. Sorry, for the management of opioid use disorders. In practice, we know that patients' subjective level of comfort with their dose is actually another important predictor of treatment outcomes. So in recent years, there's been a few studies that show that people who perceive their dose to be adequate are more likely to remain engaged in treatment, and this above and beyond of the actual dose. So with that in mind, the aim of the study was to look at the association between the dosage adequacy for OAT and the risk of HCV infection, and we defined the adequacy of dosage based on these two indicators, one coming from clinical guideline recommendations, and the other one based on patients' perceptions. And to do that, we use data coming from the HEPCO cohort, which is an prospective, open, observational cohort of active people who inject drugs in Montreal. It was initiated in 2004, and recruitment and follow-up is ongoing. The overall aim of this project is to examine determinants of HCV infection in people who inject drugs. And once enrolled, participants are seen every 3 or 6 months, and at each visit, we collect data on sociodemographics, drug use patterns, and access to services, including OAT. And we also collect blood samples for HCV testing. For the purposes of this study, we restricted our sample to people who are not infected with HCV at baseline because we wanted to look at new infection with HCV, and also to people who are eligible for OAT. And in terms of our main exposure, at each visit, we asked participants whether they were currently on OAT, and if they were, we asked them the type of treatment that they were receiving, the prescribed dose, and how they evaluated this dose to be adequate, too low, or too high. And based on this information, we created our exposure, which had 5 levels. So on one hand, we had people who are not enrolled in OAT, and among those who were enrolled in OAT, they were assigned to one of these 4 categories. So depending on whether the dose was high or low, based on what clinical guidelines recommend, and on whether they evaluated this to be adequate or inadequate. Our outcome was HCV infection, and for our analysis, our main analysis, we used Cox regression to estimate these associations. We considered several confounders. They are outlined here, and our final model adjusted for those that showed to have a confounding effect in our data. So we had a total of 513 participants. Their mean age was 36. The majority were male. Quite a significant proportion lived in unstable housing, reported recent incarceration. They had a mean duration of injection of 12 years, and about a half also injected cocaine. This slide shows the breakdown of the exposure at baseline. So of the 513 participants, about a third reported being on OAT at baseline. And of these, we found that 38% reported being on a high dose that they perceived to be adequate, 16% reported a high dose that they perceived to be inadequate, 31% reported a low dose that they perceived to be adequate, and finally, 15% reported a low dose that they reported to be inadequate. So those are pretty low numbers, but for our main analysis, we capitalized on the longitudinal nature of our study. So we had more than 3,000 observations for the main analysis. We had a total of 168 infection cases overall, and an incidence for HCV of about 12%. So this slide shows the main results of the associations between adequacy of dosage and HCV infection risk. So taking people who were not enrolled in OAT as our reference category, we found that people who were on a high dose and who also perceived this dose to be adequate had on average a 60% lower risk of infection. People who also had a high dose, but who perceived this dose to be inadequate, also had a reduced risk of infection compared to the reference group, but the reduction in risk was not as pronounced. The confidence interval were quite broad, probably due to the smaller number of events that we observed in this group. People who had a low dose and who perceived this dose to be adequate appear to have a similar risk of infection as people who are not enrolled in OAT. And finally, for people who had a low dose and who perceived this dose to be inadequate, had a twofold greater risk of infection compared to people who are not enrolled in treatment. So overall, we see this greater effect in terms of the risk of HCV infection across the different dosages for OAT. We see that the lowest risk is really for people who have an adequate dose based on the combined indicators. So people who have a dose that's in line with what clinical guidelines recommend, and a dose that is adequate when it's subjectively perceived to be adequate. And at the other extreme, for people who have inadequate doses based on both of these indicators, we saw that the risk was higher. So the study does raise some questions regarding the mechanisms, explaining some of these associations. Why do some participants had inadequate doses? And I think there's room for more research in that area. But I think that the main finding of the study is that the risk of infection varies considerably, at least in our study, according to the dosage of OAT. So from an HCV prevention perspective, it seems that simply being on OAT may not be sufficient. And in order to benefit from a lower risk of infection, participants should be on a high dose that they also perceive to be adequate. So as we are thinking about strengthening prevention strategies, moving towards elimination, and we're thinking about expanding access to OAT, I think the study suggests that we should be also thinking about the quality of treatment in addition to just expanding treatment. I think that's, and our analyses were recently published if you're interested in consulting this paper further. And that's it. Thank you.
Thank you very much. We have time for some questions.
I have two questions. One, are you going to apply that to HIV? And the second question is, in your incarceration variable, did you distinguish between provincial, 2 years less a day, versus federal, anything greater than that?
Okay. Thanks for your question. So in terms of HIV, in our cohort, the rate of HIV infection is quite low. So it would be definitely interesting to examine that in a different context. And for your second question, we only looked at any incarceration, yes or no, but it's actually a project that we're currently working on to look at jails versus prisons. So yeah, thanks.
Important topic. Did you, and I may have missed this, did you see age as a covariate with dose? And was there any evidence of residual confounding by age? Because age is a very strong predictor of transmission.
So age and duration of injection, which are quite correlated in our study, we saw that people who were on high and adequate doses were older than people, but we adjusted for them in our analysis. I adjusted only for duration of injection just because they were correlated and we didn't want to just put them all together in the model, but adjusting for one or the other ended up giving the same result.
Great, thank you.
I'm Brian Conway from Vancouver. According to clinical practice guidelines for methadone therapy, at least in British Columbia, being on a low dose of methadone is often associated with individuals who have missed doses and are actively using. So if they miss 2 doses in a row, they're cut off and they're started out at a low dose that they will just by definition perceive as inadequate. So I'm just wondering if this low dose perceived as inadequate may at least in part be a marker for higher risk behaviors, active drug use, and that's really what's driving the transmission of hepatitis C rather than it just being a direct correlate of the OAT dose.
Well, I think there's 2 parts of my answers. First, we adjusted for some variables that are proxies for high risk behaviorals in our cohort. So we did try to diminish that confounding risk. The other thing is some people go on OAT not with the intention of not stopping completely to use drugs. They might just want to reduce using drugs, and if that's the case, I mean. I think what the study suggests is that maybe this is something that should be discussed during dosing decisions in practice. Maybe they should be given access to other prevention tools in addition to OAT. So,
One last question, please.
Hi, I'm Matt Bonham from Halifax. I actually did a commentary on your research there. A question I have, and I've been on OAT on and off for like 8 years, and I'm just wondering like where the 16 milligram baseline comes on compared to like, say if you took everybody's dose and made an average, like from my experience, it's like 80, 100, 120. So it's just like a low baseline of adequate/inadequate doses.
It's been based on some studies that were carried out quite a long, like 10 or 20 years ago, looking at the relationship between the dose and treatment outcomes in addiction, so craving, withdrawal, and those studies seem to conclude that a minimum of 60 milligrams on average, so it's not for everyone, but in the average population, that seems to be more beneficial than anything below that.
But that's 10, 20 years ago?
Yes, well, 2000s, I think those papers are 2000s, yes. So maybe I see your point. Actually, in our paper, we did stratify the dose into tertiles, and one of our categories is 80 milligrams or more. And we see this dose, this graded effect for people who have very low doses, moderate, and very like higher, more than 80 milligrams. So I think that kind of goes in the direction.
Thank you.
Thanks. I think we have to close it up, but thanks very
Thank you.
much for a really interesting session, everybody, and the speakers and audience.